Thank you, Claire. And thank all of you for joining us today to talk about the GI360 stool profiles from Doctor's data. I'm looking forward to sharing this information with you. I'm one of a team of clinicians who consult with DDI practitioners on these test results. And in this overview webinar, we're going to explore how the GI360 microbiome testing can reliably provide an evidence-based and clinically actionable view of your patient's gut health. So let's begin. And for those of you who are newer to Doctor's data, we've been here for more than 50 years. DDI has been a federally licensed CLIA laboratory and is recognized and respected by many American and European regulating and governing agencies. We do maintain a rigorous commitment to international standards of excellence. All of our licensing information is found at this link up at doctorsdata.com. To begin, let's briefly review today's objectives. We'll start by briefly mentioning the role of the gut microbiome in women's gastrointestinal, hormonal, immune, and metabolic health, along with the other key factors that influence it, including medication-associated changes. We'll then discuss which patients may benefit from comprehensive stool testing, and then compare the GI360 Complete with the GI360 Select. And then finally, we'll review a few practical collection considerations as well. And then to conclude, we're going to walk through the GI360 Complete report, a sample of that, and discuss how to interpret the findings and apply them in a clinical practice. I know this might be a review for many of you, but let's briefly revisit why the microbiome is such a central focus in women's health. It's an important context for interpreting the results of the GI360 with today's session focus on women. As shown here, the gut microbiome sits at the intersection of hormonal, neurological, immune, and metabolic pathways, communicating bidirectionally with each. Because these symptoms are interconnected, disruption in one can influence the others, contributing to symptoms that extend well beyond the GI tract. Chronic stress is a clear example of this network in action. And of course, that applies with most of our women patients. It simultaneously alters endocrine, nervous, immune, and metabolic function, reshaping the gut microbiome, which can then influence these same systems in return. This bidirectional relationship helps explain why stool testing can provide clinically meaningful insights across a wide range of patient presentations. Let's look at how chronic stress affects the gut microbiome. While stress is not the only factor that shapes the gut microbiome, its effects are well documented in the peer-reviewed literature. Chronic physiological or psychological stress through persistent activation of the HPA axis, hypothalamic pituitary adrenal axis, and elevated cortisol has been associated with reduced microbial diversity and lower abundance of beneficial organisms, such as the cornerstone species, Bifidobacterium, Lactobacillus, and the Akkermansia species. These are all markers seen on all of the GI360 profiles. Declines in these species, among others, can ultimately result in reduced butyrate production as well. Together, these changes may compromise the gut barrier integrity, alter metabolic signaling, and promote a more pro-inflammatory environment in the gut, and create conditions that favor the expansion of opportunistic organisms. This relationship is particularly relevant in women's health, where hormonal transitions may further influence the interaction between stress and the gut microbiome. Importantly, though, these microbiome alterations may both result from chronic stress and perpetuate gut dysfunction through the gut-brain axis. In addition to this sympathetic dominance, increasingly we also recognize that medications can significantly influence microbial composition and function. The relationship between medications and the gut microbiome is well documented and is bidirectional. In other words, gut microbes can influence drug metabolism and therapeutic response, while medications such as proton pump inhibitors, metformin, statins, incretin-based therapies like the GLP-1s can alter microbial diversity, composition, and function. Incretin-based therapies are highlighted first because they are rapidly expanding in use across the world and are increasingly being studied for their effects on gut physiology and the microbiome. Through changes in appetite, gastrointestinal function, and metabolism, they may indirectly reshape the gut microbial environment. With the growing use of the oral formulations that have direct mucosal contact, this still remains an active area of research. Neuropsychiatric, hormonal, and anti-inflammatory medications also demonstrate important microbiome interactions. SSRIs may influence microbial structure through antimicrobial effects and oxidative stress pathways. Atypical antipsychotics are associated with reduced bifidobacterium and lactobacillus, the cornerstone species, and increased Firmicutes phylum, which may contribute to overall metabolic effects. Hormonal contraceptives represent an emerging area where microbiome composition may also influence physiological response. Cannabinoids, including CBD and THC, show bidirectional interactions with the microbiome as well and have been associated with increases in the Akkermansia and the Faecalibacterium prausnitzii species. Taken together, these medication classes highlight an important clinical point. Pharmacologic therapies can meaningfully shift microbial balance and should be considered when interpreting stool testing. As our understanding of these microbiome, chronic stress, and medication interactions grows, an important question becomes which patients then may benefit from a more comprehensive assessment of the gut ecosystem. In addition to those patients on long-term medications, stool testing is most appropriate in patients with established GI disease, for example, IBD, IBS, or any suspected infection, and persistent or refractory symptoms. It may also be useful in metabolic, inflammatory, immune, and neurobehavioral conditions as well in patients with very poor quality diet, hormonal imbalance, and then, of course, obesity. Clinically, low iron and ferritin are frequently seen alongside dysbiosis and intestinal immune activation. I hear this often in my consults. Although the GI360 does not measure iron status directly, and iron deficiency is multifactorial, microbiome imbalance may contribute through effects on inflammation, mucosal function, and iron regulation. Once you've identified an appropriate candidate for testing, the next step, of course, is to select the correct GI360 profile that best suits the clinical question at hand. The two that we're looking at today would be the GI360 Complete and the GI360 Select. They both include the PCR detection of the beneficial microbiome and the common GI pathogens, along with a measurement of the beta-glucuronidase activity. The GI360 Complete provides the most comprehensive evaluation, adding in microbiology culture with antimicrobial susceptibilities, parasitology via microscopy, and a full panel of stool chemistry markers. Although the H. pylori antigen testing is not included in the GI360 Complete, it is available as an add-on profile to the GI360 Complete if needed. As mentioned, the GI360 Select offers a streamlined approach that includes the same PCR assessment of beneficial bacteria and the scoring system and the GI pathogen report. It also includes that H. pylori antigen testing and most of the stool chemistry markers. It excludes the microbiology cultures, parasitology by microscopy, and the lactoferrin inflammatory marker from the stool chemistries. Before reviewing the report itself, let's briefly discuss a few collection considerations that can influence test results and their interpretation. Proper specimen collection is important for accurate interpretation, of course. Collection guidance is included in each kit and also online. While not directly contraindicated, we do recommend patients ideally discontinue any antimicrobial, antibiotic, antifungal, probiotic, and the Saccharomyces boulardii for at least 2 weeks prior to collection when clinically appropriate, as these therapies can influence microbiome composition. Other medications are also mentioned within the instructions, but discontinuing medications is, of course, a clinical decision that may not be appropriate for all patients. Therefore, results should always be interpreted in the context of any current medication on board and any supplement on board. With proper collection guidelines in place, now let's look at how the GI360 profile characterizes the gut microbiome, beginning with the targeted PCR technology explanation. As a quick review, PCR amplifies organism-specific DNA targets, enabling a highly sensitive, standardized, and reproducible detection of microbes in stool samples that may be missed by other conventional methods. With PCR detection, standards do matter. The GI360's FDA-cleared and CE-marked probes have less than 5% variability between runs. This high level of reproducibility has been confirmed in both European and US research laboratories. Maintaining this level of consistency is critical to avoid false positives and, of course, false negatives, ensuring that clinicians can rely on these results for accurate patient assessment. Reproducibility is only one component of a clinically reliable assay. Beyond generating consistent results, a test must also accurately identify its targets and demonstrate clinical relevance of those targets. So just because we can find it doesn't mean that it's relevant with how your patient's microbiome is being assessed. This is where assay validation becomes essential. PCR-based microbial detection methods vary in performance across the industry. At DDI, assays are validated for sensitivity, specificity, reproducibility, and clinical relevance with published data and independent peer review, supporting scientific rigor and reporting reliability. This level of validation helps move microbiome testing from informational results to clinically actionable insights that support more precise therapeutic planning. With assay validity established, now we will compare how different molecular approaches evaluate gut bacteria, specifically genomic sequencing versus the PCR detection. Analytical validation is what makes test results clinically actionable. While metagenomic sequencing offers broad research-focused microbial profiling, it currently lacks standardized reference ranges and clinical validation. In contrast, targeted qPCR provides validated, clinically interpretable results. With that mild foundation, let's look at how the GI360 profile integrates these technologies into a report designed for your clinical decision-making. This is the first page of all versions of the GI360, which provides a concise overview of the patient's microbiome status. The microbiome hexagon, the dysbiosis index, and diversity scores summarize how the patient compares to a normal biotic reference population, now over 5,000 subjects. All versions of the GI360 use 45 targeted PCR probes representing over 300 bacterial species identified in peer-reviewed microbiome research, helping identify dysbiosis patterns associated with conditions like IBS and IBD. We'll examine each of these assessment areas separately. Next. Here we see the microbiome hexagon, which provides a visual overview of the patient's bacterial abundance across 6 key phyla relative to the normal biotic reference range shown in green. So green is normal biotic. The white overlay represents the patient's microbiome profile, allowing you to quickly identify broad patterns of microbial imbalance and ecosystem disruption, with color coding, represent the standard deviations above and below that green normal finding. To further standardize interpretation, making it easier on clinicians, the GI360 profiles, all of them, provide the dysbiosis index and diversity scores. The dysbiosis index, reported for patients aged 2 and older, compares bacterial phyla findings with higher scores indicating greater dysbiosis or imbalance of beneficials as compared to our normobiotic population. Clinically, the lower DI score is normobiotic at a 1 or 2, so lower dysbiosis is better. This only refers to the beneficial microbiome, too. The scoring system has nothing to do with anything else found in the test. The diversity score, which is the second score, reflects the microbiome's functional resilience. Some would argue that's even more important in some of these cases. Lower diversity may indicate reduced ecosystem stability and diminished support for gut metabolic signaling, particularly in those patients with reduced dietary intake states like the GLP-1 users and others. Clinically, a higher diversity score at 4 or 5 is ideal. So high diversity, low dysbiosis. To summarize, the dysbiosis index and diversity scores together provide a simple, integrated view of overall gut ecosystem balance. Also provides a very easy way for the patient to sort of see how they're doing in terms of their treatment, and any sort of a retesting that you do, they can look at their scores, and it is a nice compliance tool. Clinically, reduced diversity or increased dysbiosis may help contextualize variability in GI tolerability and metabolic response, including in patients on medications like GLP-1s. And importantly, these markers are not to be used to determine whether these metabolic therapies will work, but rather to better understand differences in individual response patterns to these drugs. Beyond the global scores, the GI360 profiles also evaluate functional microbial organization. The GI health markers section on the first page groups bacteria into functional guilds, which are microbes that perform similar roles within the gut ecosystem. This provides additional context to the dysbiosis and diversity scores by highlighting changes, larger changes, in gut barrier support, short-chain fatty acid production, and insight into the endogenous GLP-1 related metabolic signaling. Details on the organisms included in each guild are available up at doctorsdata.com. Following the summary page, then, the next 3 pages examine individual bacterial members across the 6 beneficial phyla represented on the hexagon. This is the detailed view of the beneficial landscape. Basically, I call it the deep dive, the details. Next, using a sample report, we'll highlight key patterns and clinically relevant findings that can help guide interpretation and, of course, therapeutic decision-making. This is the first page of that deep dive. Individual microbial results are reported as standard deviations from a normobiotic reference population, just like the hexagon, with values in the green triangle range considered to be normobiotic, very typical. Deviations away from green may reflect influences such as diet, stress, medication use, antibiotic exposure, or GI inflammation. These findings can help guide targeted interventions, such as direct probiotic therapy based on some of the findings, as illustrated on this page by this low bifidobacterium result. The comments section at the end of the report will highlight all out-of-range findings, so anything that's not green will be talked about in the back of the report, and we'll summarize these bacterial known associations with any symptoms, any diagnoses, diet issues, and any chronic inflammatory disease. This is the next page where we're showing the Firmicutes phylum. We see a declining number, isolated for you, we see a declining number of butyrate-producing bacteria. on this particular report, which may eventually compromise gut barrier integrity and anti-inflammatory signaling. Lactobacillus on this page down below that remains within the normal reference here, while elevations in the Phascolarctobacterium and the Mediterranobacter novis provide additional context. The Phascolarctobacterium is a propionate-producing organism, propionate being one of the short-chain fatty acids, whose abundance is influenced by a more pro-inflammatory condition. Doesn't cause the inflammation, it is elevated in the presence of inflammation due to other things. Diets, it will also elevate with diets that may not be properly balanced and any overall microbial ecology issues. The Mediterranobacter novis has been associated in the literature with mucus utilization and also with inflammatory states, just like the Phascolarctobacterium, when overly represented. Together, the loss of butyrate producers, which I've identified in that long rectangle, together with this loss of butyrate producers, this pattern, all of these findings suggests an impaired fermentative capacity and highlights opportunities for targeted probiotics. For example, a probiotic that contains more bifidobacterium than lactobacillus, which was normal. We would always encourage an increase in the soluble fiber when we see these members starting to drop off, and we'll talk about soluble fiber later. And then, of course, dietary strategies to restore microbial balance, which will always default to a more Mediterranean-style diet. This is the final page, the final microbiome assessment page, and it highlights additional key organisms, including at the bottom, the Akkermansia muciniphila, which is a species associated with mucosal barrier integrity. So it recycles the gut lining. It uses it as fuel and recycles the gut lining. Also interacts with immune modulation and with intrinsic GLP-1 signaling. So those patients on a GLP-1 or thinking about a GLP-1 should really pay attention to the Akkermansia to take advantage of what is innate. In this case, it is low, as you can see. And we're going to talk about this member here more because it is so intricate to the microbiome. Given its functional relevance, the Akkermansia muciniphila species warrants special attention as a key organism related to incretin-based therapy patients, the GLP-1 patients, and other reduced intake patients. So we're always thinking about diet when this member goes low. Lower levels are associated with reduced diversity of the microbiome, metabolic dysfunction, lower polyphenol intake, and diminished mucin availability if this member is not up to par. It is certainly not a leaky gut test and a leaky gut finding here, but we do want to pay attention to how do we keep our microbiome and our mucosal lining healthy. And it's one of the ways is with this member. Higher levels of this member may accompany improved metabolic health. So those patients who are actively losing weight and having enhanced insulin sensitivity, sometimes we do see this member go high with those members on the GLP-1s. Importantly, it remains unclear whether level changes are a direct effect of the GLP-1 therapies or are secondary to reduced food intake, altered gut physiology, and improved metabolic status. Overall, Akkermansia is best interpreted as a marker of broader gut ecosystem function and are context dependent. So we see the gut as a big concert, a lot going on. When low, the current literature indicates that this member seems to respond to dietary polyphenols, such as the pomegranate here, any bright colored foods, raspberries, blueberries, etc. They all provide quite an array of polyphenols. So back to the Mediterranean-style diet with all of the polyphenols included with olives and brightly colored foods. That is always our best guidance for patients. While PCR provides the highly sensitive detection of these targeted organisms, the GI360 Complete also incorporates culture-based methods to broaden microbial assessment outside of the molecular primer and provide additional clinically actionable information. Cultured organisms are identified using MALDI-TOF, which is mass spec. It's a powerful analytical technique allowing rapid and accurate species identification. For specific bacteria reported at greater than or equal to 3+ growth and yeast at greater than or equal to 2+ growth, inhibition testing is also performed based on peer-reviewed thresholds, providing you actionable information to help guide personalized treatment. We put the stool in vitro with both natural and pharmaceutical agents. This would be an example of the findings for an inhibition result for this Citrobacter species. So this is your example. We, as I mentioned, report out natural and pharmaceutical therapies to help you guide treatment. You'll often see that a patient may or may not be amenable, may not respond to what you might assume would be perfectly fine to give them. So this is really actionable. It's very functional information, is very unique to the patient, and is just simply not available through PCR or metagenomic sequencing, which supports a more individualized care plan. We now move from microbiology to the GI pathogens profile, looking for pathogens, usually found in the GI tract. We use FDA-cleared multiplex PCR probes to detect 8 bacterial pathogens, 3 viruses, and 3 parasites associated with a GI illness. Because of their potential clinical significance, positive results on this report are released to the practitioner as soon as they are available on the portal, oftentimes even before the full report is finalized. Results with PCR are qualitative, indicating the presence of a pathogen DNA, and should always be interpreted within the clinical context of the patient's presentation. The microbiology community really often prefers that there are obvious symptoms with the patient before treatment is administered. No symptoms, treatment is not required, and it may be just transient DNA or a past exposure. We would prefer that you support the microbiome, and usually when there is a positive finding like this, C. diff toxin AB on this, oftentimes the microbiome is insufficient. So we would prefer supporting the microbiome instead of direct treatment when there are no symptoms. When available, the PCR findings from this report can be interpreted alongside the culture and the parasitology results. There are crossover markers here, adding valuable additional clinical context. So if it's cultured out, it is an active infection. If it's found under microscopy, it is an active infection. So there is a good crossover here with looking for the DNA versus other methodologies. And this is on the GI360 Complete. Let's continue with another complementary methodology that I've already mentioned, the parasitology profile. When interpreting the parasitology profile, pay particular attention to patients with a history of either international travel, innocent pet exposure, raw or undercooked fish or meat consumed often, or persistent GI symptoms despite any prior treatment. The parasitology profile uses microscopy with 3 separate days of stool collections, if possible, as the recommended gold standard. That will help improve detection of intermittently shed ova in parasites. Not always possible with very constipated patients, but do your best there. The report identifies more than 30 commonly encountered organisms with the ability to expand the reference library as needed. Standard of care treatment guidance is provided for any out-of-range parasitology finding at the end of the report. One important clarification that I want to give to all of the clinicians is that when a patient identifies and wants to submit a visible specimen that they find that requires further identification, that you want to be sure, number one, that it's a parasite specimen and that they can collect. Macroscopy is not automatically performed in every parasitology, but is available as a separate profile. The macroscopy ID profile is a separate order to assist you with that characterization. The other markers section at the end of the parasitology profile reports common stool artifacts that are not organisms, but may provide additional clinical context and support the interpretation of your overall findings. Here on this sample, we see positive vegetable fibers, which is commonly found with those patients who are eating on the run or incomplete chewing. It doesn't necessarily indicate the need for digestive enzymes here. It's commonly found. Another notable finding here under other markers is the presence of dead microscopic yeast. This is under a microscope, not a culture. So that is different, of course, than the culture finding for yeast. This finding can suggest recent or ongoing fungal die-off activity within either the large intestine, where we may have cultured something, or possibly the small intestine higher up, living somewhere higher up, causing symptoms, dying off in transit to arrive to the bowel. So that is more information for you to determine. Building on this, then, this profile, the stool chemistries marker profile provides additional clinical clues for you that help strengthen suspicion of that upper GI or small intestinal fungal overgrowth, along with the patient's symptoms, which can include upper GI gas, pain, bloating soon after eating, may not have any stool pattern irregularity whatsoever. It may all be upper GI, and it could also include intermittent reflux or nausea. And finally, we come to the stool chemistries markers, beginning with digestion, or the markers, this section, I've divided it in sections here. This page includes the digestion, the inflammation, the immunology, and the short-chain fatty acids. Within the digestion absorption category, elastase evaluates the pancreatic enzyme output and digestive capacity. While low levels of elastase, especially with those sympathetic dominant patients, may suggest intermittent pancreatic insufficiency, results should always be interpreted within the clinical context as factors such as stool consistency, diet, and other non-pancreatic influences can affect this value. If low, retesting this marker after whatever else treatment-wise you're doing, if low, retesting this marker in 4 to 6 weeks into the future is recommended. If it's still low, we would always refer out to a specialist for imaging on this marker, if low the second time. We don't want to miss that. Next, the inflammation category on the GI360 complete includes calprotectin and lactoferrin, which are markers most associated with inflammatory bowel disease. Lysozyme is also included and is a broader marker of innate immune activation anywhere within the GI tract and may be observed with dysbiosis, any overgrowth that we might have detected, SIBO, barrier dysfunction, diverticulitis, or inflammatory bowel disease as well. Lysozyme is often more sensitive to microbiome-related immune activation than other inflammatory markers. Below that, in the immune section, secretory IgA reflects mucosal immune function. Elevated levels suggest active immune stimulation by something, organism, food sensitivity, autoimmune condition, while low levels may indicate a more impaired mucosal immunity or chronic immune suppression. So something may have been going on for a long time, provoking the immune system for a long time. Among these functional markers, the short-chain fatty acids is next and deserve a special attention slide because of their central role in gut barrier integrity, host metabolism, immune regulation, and the microbiome-mediated signaling. Short-chain fatty acids, produced through beneficial bacteria fermentation of soluble fiber, are essential for gut barrier integrity, immune regulation, and metabolic health. Butyrate in particular fuels colonocytes, supports tight junctions, promotes anti-inflammatory signaling, and stimulates intestinal L cells to release glucagon-like peptide, GLP-1, linking the microbiome to appetite regulation and glucose homeostasis. For women, poor dietary patterns for whatever reason, chronic stress, hormonal transitions and weight management strategies, meaning Lower food intake can also influence microbiome composition and these butyrogenic species, producing the butyrate. Diets low in fermentable fiber and plant diversity may reduce microbial fermentation with downstream effects on gut barrier function, immune resilience, and the endogenous GLP-1 signaling. Supporting a diverse, fiber-rich microbiome is therefore an important strategy for digestive and metabolic health. So if butyrate is so important, how do we support its production clinically? And the answer begins with fiber, but not all fiber functions the same way. Soluble fermentable fiber is the primary substrate for short-chain fatty acid production and butyrate production. A therapeutic target for many adults is between 8 and 15 grams daily of soluble fiber from supplements such as resistant potato starch, inulin, or psyllium husk, or from foods including legumes, Jerusalem artichokes, chia seeds, bananas, and many other foods that contain soluble fiber. However, obtaining a therapeutic amount from food alone can be challenging for the patient due to the volume of food required to meet the threshold of what is therapeutic. Food shares space between soluble fiber and insoluble fiber, so oftentimes what you could get in, say, 1 tablespoon of inulin turns out to be a cup and a half of legumes. So legumes may not even be reasonable for some patients. So food may or may not be your best advice, but they should be aware that that sort of food can only help. But in cases of where butyrate is very low or the membership is very poor, you may want to default to a more guaranteed way to get into that therapeutic dose. Insoluble fiber, on the other hand, contributes less to the short-chain fatty acid production, but does support stool bulk and healthy stool transit. A typical insoluble fiber intake goal would be 15 to 20 grams or more daily coming from vegetables, fruit, flax, bran, things that don't dissolve. I find that many patients and some practitioners may be unfamiliar with the different types of fiber, think that they're doing great eating plenty of vegetables and fruit, and that is sufficient. So in this regard, patient education is very important. When low butyrate or total short chain levels are identified on stool testing, focusing on the type of fiber, not just the amount, can help guide more targeted microbiome support. Speaking of type of fiber, consider resistant potato starch when the GI360 shows low butyrate, low total short chains, elevated stool pH, a more alkaline stool is what that is, low diversity score, or reduced butyrate producing members on the GI360 within the Firmicutes phyla. Most notable of these species being the Faecalibacterium presnitzi, the Lachnosbrachiae, and the Ruminococciae are all within the Firmicutes phylum. Consider inulin as an option when the GI360 shows low Actinobacteria phylum and or low Bifido species. Inulin supports acetate and lactate production, which can indirectly enhance butyrate production through microbial cross-feeding. Finally, psyllium husk is a partially fermented fiber that supports bowel regularity, stool consistency, cholesterol metabolism, and glycemic control. You may consider psyllium in cases of constipation, elevated stool pH, so the more alkaline bowel, or during recovery from intestinal inflammation when a gentler fiber is preferred. Building on the previous sections of the stool chemistries panel, we see the intestinal health markers, which finishes off the stool chemistry profile. These markers provide additional functional insight into microbial activity and the intestinal health. They include stool pH, alkaline or acid, occult blood findings, and the beta-glucuronidase marker, which is a microbial enzyme. It's an enzyme created by the microbiome that reflects digestive and inflammatory activity. Elevated beta-glucuronidase may influence drug metabolism, hormone recycling and toxin processing, and may warrant further clinical evaluation. Occult blood suggests an upper GI bleed. This is hemolyzed blood. Patient will not see occult blood. If they report seeing blood, that's more of a red blood cell finding, usually not the occult blood when you can see it. It is very distinct from that red blood cell finding, which is usually associated with hemorrhoidal sources. Macroscopic appearance findings can also provide supportive clinical information. Is the stool hard and firm? Is it loose and watery? They all that would also sort of be the additional markers that you would coincide with anything else that we found in the test. Together with the previous sections, these markers on the stool chemistries page provide a more comprehensive view of gut and immune function to guide your patient's care. The GI360 report, both reports conclude with 3 to 4 pages of detailed commentary for any markers found outside the normal range, as I've mentioned, including the beneficial microbiome constituents, if they're high or low. Standard of care recommendations for any GI pathogen are provided, along with guidance for any out-of-range stool chemistry markers as well. And once targeted interventions have been implemented, we're always going to recommend retesting so you can determine whether those strategies are producing meaningful microbiome and clinical changes over time. Smaller standalone DDI panels are much more affordable and can support patient compliance by retesting at least 2 weeks post-therapy. So treat them for what you find, pull them away from treatment, any sort of probiotic therapy, and then you do the collection once the microbiome has stabilized. And this slide just lists some of the most commonly used retesting profiles as needed. And finally, because of the known linkages to other body systems, this slide reflects some of the other options that would be appropriate as complementary testing options for any stool testing patient, depending on the specific presentation or concern. We at DDI and Claire as well, and anyone on our clinical education team can certainly guide you on the most appropriate next step testing strategies based on the stool test treatment results and the patient presentation and their history. And that concludes my presentation. I thank you for joining me today on your evening. I hope it's shown how the GI360 delivers meaningful, actionable insights into your patient's gut health. We appreciate your commitment to improving patient care, and we look forward to supporting you as you apply these tools in practice. Feel free to visit www.gi360.com or Doctor's Data to access videos, our publications, and any educational resources, including our searchable GI360 resource guide to assist with interpretation. And then all my references follow this slide as additional information.